Sup, guys? Welcome to the PT Good podcast, where we talk all things ortho, from physical therapy to training. My name's Kane.
And my name's Mark.
So, what is on the agenda for today, Mark?
All right. So today what we want to discuss, what we want to talk about is discharge and prevention. In the previous episodes, we talked about what follow-up appointments look like, what reassessment looks like. Now we're starting to look towards the end of the road. What do we look for when we think a patient's ready for discharge? What do we look for to provide them with so they're able to continue caring for themselves after discharge and possibly prevent recurrence of whatever issue they were coming for? So, Kane, what do you look for? Do you have any kind of specific criteria you look for discharge for different kind of patient presentations? You trying to get them to a certain level? Is it, any certain key factors that you're looking to for the patient to control before you say that, they're good to go on their own?
Yeah, so there's definitely a couple of things that I typically will look out for. The first thing is, did we get them back to accomplishing their initial goal at the evaluation? And I use that a little bit more loosely. I feel like on eval, when you ask them, what are your goals for physical therapy? What do you want to get out of rehab? What's a successful rehab look like to you, or anything along the lines of that? Most people honestly haven't put enough thought into it. They're just like, I don't want to have pain. I don't want to hurt, or I just want to be able to move my arm. And that to me is like, they haven't actually thought about what their life is going to look like without pain, or following the course of PT. So I will usually check in and always ask them, just like we talked about on previous episodes, what are some things that you still struggle to do? And what are things that you're able to do now compared to before? So it's just like a constant working or living document, essentially, of what can we consistently be updating and changing as their goals change, as their function improves. So those are the huge things that I typically look for in regards to considering patient discharge. The other things for myself are just making sure your usual assessments, is their range good? Is their function good? Is their strength fine? Do they have any other lingering deficits that may come back to give them issues down the road? And I want to make sure that we kind of tie those up. And I usually like to do it in a way where they may not even notice that that's what we're working on. They're focused on their goals. I'm focused on their goals, as well as the deficits that I want to improve on, specifically to hopefully prevent a recurrence of this issue. What about for yourself? What are some of the things that you typically look for when you're considering discharge for someone?
Yeah, I mean, I definitely take the similar approach to you in that I have my expectations for discharge criteria, while also taking into account the patient's, how they feel in terms of being ready to be done with PT. So, I'm reassessing their impairments, getting their idea of how they think their function is, how they're able to move, and seeing where they are at in terms of their goals. Yeah, like you said, some people, I mean, especially if they've had the kind of issue for a long time, maybe they're like, oh, I just want to be able to move without pain, right? They're not even thinking about, hey, I want to start going back to the gym. I want to, be able to run again, things like that. So as they're improving, maybe the goals are changing, right? Maybe their expectations are differing, so they feel they're able to do more, right? So, it's just getting I think the patient's perspective is certainly the primary thing I'm looking to meet when it comes to discharge criteria. But at the same point, there's some impairment-based criteria we're looking for as well. When it comes to, when I say impairment, I'm not saying I want them to be at a specific range of motion. Typically, that's tied in with function, right? I want to be able to bend forward enough where I could pick something up. I want to be able to move my arm, behind my back, lift overhead, things like that. So usually if they're able to do that, we can say the range of motion's there. That kind of ties in. But there's certain presentations where maybe the patient, has decrease their pain enough where they can do everything they want, right? Let's say like a cervical radiculopathy for some reason. Oh yeah, maybe they, their pain is down to like a 2 or 3 out of 10. They can do everything they want, but they still have numbness or tingling, down the back of their shoulder to the dorsum of their hand, right? It's just kind of like, okay, from my perspective, even though maybe they have met all their goals, I probably want to address those symptoms still, right? So that's a case where there's an impairment or a presentation that, even if the patient feels they're ready, we have to have the conversation of, hey, I think we should address these symptoms so that, what you're coming for is fully resolved or healed, right? So yeah, I kind of tie it in, right? We look at an impairment-based approach from, our professional view, and then we get some input and feedback from the patient as well, where they feel they're at. How do you have
Uh,
any kind of like Oh yeah, go ahead.
I was just gonna add to the one point that you mentioned was like checking in with your patient. I think that's like super super important to
Yeah,
do, which is making sure that they're like psychologically ready for discharge.
yeah,
I feel like there's a lot of patients who can come in and they've met all their goals. They can do everything just fine, but they are scared to step back out and live their own life
yeah,
because they're like, I don't want to get hurt again. I don't want to do this. I want to have your guidance and etc. And I think that that's where just like making sure that you have educated your patient enough, that you have given them enough autonomy and independence while you're treating them to make sure that they are ready and that they realize that they're capable of more than what they may
yeah,
be, than the limitations that they put on themselves.
yeah,
And I find that this conversation is so much easier to have when I check in with patients where I'm like, hey, so I've noticed that your function has improved. How much would you say that it's improved? Do you think that you're ready for discharge or for you to be done with me? Do you need me in any other way? Is there anything else that I can help you with, or that we need to like close up on any loose ends? Anything else that you need information with, and stuff like that? And a lot of times when it's presented in that manner, a lot of patients, as they've gone through it, you've pretty much done all that groundwork leading up to that conversation.
yeah,
So by that time, you should already know, like, okay, there's like one or two things that we just need to catch up on, and we're good.
yeah, yeah, yeah,
Or
for sure.
at that point, the patient may just be like, oh no, I think we're good. I'm ready
Yeah,
for this to
yeah,
be my last session.
yeah. Especially if they understand, like you're reassessing them, you're telling them what to look out for in terms of symptomatic response. What they're supposed to look out for in terms of function. They may get to the point where you have an appointment that, like, hey, you know you've been telling me to look out for, like, any lasting stiffness, any like symptoms in my leg, and I haven't really noticed that. I've been back to doing the stuff I was doing before I had any kind of symptoms. So they're already their expectations for to be discharged. They already, they know your criteria in some way already. So it's not even, they may be basing their discharge off, or they have an idea of what you're looking for. They know what they're looking for in terms of their function. Yeah, everyone's on the same page through the whole process. I mean, I even get patients too where, um, they're like 85% of the way there, something like that. And like, okay, how about, you're doing good. You've been doing good. It's been consistently responding positively. How about we schedule something for like 3 weeks from now? And they'll come back and they'll be like, hey, I was 85% last time, 100% this time. And I'm always thinking in my head, like, why did they even come back? But when you're following this kind of, reassessment process that we're doing, they understand the value in it. They're like, all right, this person's professional. They're looking for specific things when it comes to my movement, symptomatic response. They have a interest in, what happened over this amount of time that they haven't seen me. So yeah, there's value in that reassessment and stuff like that. So like you said, the patient maybe knowing when they're ready. Um, yeah, even people coming for that reassessment when they know they're good, like they value that reassessment and what you're looking for. Do you try and, like, people who you think maybe hang around a little bit too long, or aren't maybe a bit hesitant about, say, cutting the cord? Like, is there a certain way you try to combat that, or that people who are hanging on a little bit more? Like, how do you start to taper them off?
So I naturally build in a taper based on my expectations. I've gotten pretty good at determining when I need to discharge people and like how things are going to lead up in regards to like predictions of their prognosis based on like their symptoms, my
Hmm.
findings, their response, and stuff like that. So many of my patients recently have actually been so surprised because they're like, oh, so we're cutting down to once a week and then twice a week, or and then once every other week, and then we're kind of done. By the time that we get up to that point and it's the last visit or two, they're just like, oh wow, you were pretty spot on in regards to that. And so I think that having that expectation set out on eval, like, hey, you're going to be here when I need you to be here so that I can manage your symptoms and
Yeah,
get you better faster. But as you get better, I expect you to be able to do this on your own. I'm going
sure.
to
Yeah,
teach you all
yeah,
the
yeah.
things that you need to know leading up to that. And then by that time, they're just like, oh, yeah, I don't really have any symptoms. I feel a whole lot better. I know the things that you taught me and like what to continue doing in regards to that. So those conversations are a whole lot easier to have.
Yeah. Do you
When
ever
it
do
comes,
something where you have a built-in taper? Do you ever do something? Do you ever make the visits more frequent? Like, are there cases where you have to go the opposite direction, see people more frequently?
yeah, so there are times where I will have to add on more visits, and that's okay. That's normal. I usually will tell my patients like, hey, so I'll schedule you out. It's easier for me to get you in on my
Yeah.
schedule right now before it fills up. But if we don't need all these visits, I can just cancel them out. And if you need more, I can certainly give you more. I have no issues with that. I think the hard part is when a patient is not ready to fly on their own, or in the worst case here, I find it where patients will not do something on their own. They will only do it if they come, and that is a hard conversation to
Yeah.
have with them. But I am very quick to tell them like, hey, you know everything that you need to do. Like you know how to manage your stuff. You know that you need to put in the time and effort. I cannot force your hand to do this. I am not someone who's going to just essentially babysit you to take care of yourself. You know, you have all the information, all the tools that you need. It is up to you to do the rest. And if they're not okay with that, that's just one of those things where it's like, hey, I really cannot justify medical necessity in regards to seeing you anymore because I've taught you everything. You've made progress. You've done all the things. You just need to be able to give it time and the due diligence to actually see it through. And that's something that I can't control. That is something that is ultimately on the patient themselves to make happen for themselves.
Yeah. I don't even. I try not to even entertain that conversation anymore. There's just not. It's not. At least in the United States, like the model isn't set up for someone to continuously attend therapy when it's not justifiable, right? Like, I mean, self management's the goal, right? And typically it's achievable. I can't really think unless they have, unless it's like a maintenance therapy type thing, someone has like some kind of progressive neurological condition, I mean, which is not the population we're speaking about, but someone who's has pain that's under control and they're managing on their own, like, and it just, you know, oh, I mean, I've had people say something, oh, I'm not going to do these unless I come here. Okay. Yeah. Okay. I could see a little bit more frequently to start, but we have to taper off. There has to be an end, right? There has to be some kind of plan. So that's yeah, it's something you run into, right? But yeah, being upfront with people is usually the best thing. It's not, maybe, hey, I mean, maybe there's clinicians that, yeah, they'll see you 3 times a week for 3 months, even, if you're all the way better, but it's just not, yeah, not, not us, right? Just not,
Yeah,
it's not, yeah, there's a multiple factors. There's the insurance thing. There's also just like the ethical thing too. Like it's not justifiable.
yeah, and I found there are some patients that I will certainly keep on my caseload longer, and others where they're a lot shorter, right?
Hmm.
So I think for patients who have, let's say, for example, like non-responsive low back pain, I'm probably gonna have to keep them on my
Yeah.
caseload a little bit longer. It depends on how they are as a patient. Like there are times where I teach them all the exercises. They're like, okay, I'm good. I know this is what I need to do. This is how I progress. Awesome. I don't need to keep coming here. That's cool. And then there are other patients where their symptoms just don't really change much and they don't respond. And because they're not responding, because they're kind of at a plateau, we have two options. The first one is to continue monitoring them and progressing them as necessary. So to me, that's like improving their activity tolerance, their functional capacity, etc. But on the flip side, if they are that plateaued, you may be able to just tell them, hey, like we're not seeing any progress. It's okay for you to continue doing this at home. If things change, come on back in. That's okay. Yeah. You know, it's not like you're just trying to get rid of them, but at the same time, you've given them what they need to be able to continue on their own. So I think that there are definitely some cases where I'll keep people on for longer when they need it, especially if like some things pop up. Like I had this patient, for example, she pretty much had like non-responsive low back pain for the most part. It was like it got better mechanically, but she has like super severe scoliosis and she just does not move terribly well. So a lot of it is like general exercise and just making sure that she moves better. But recently she actually ended up getting like shoulder pain and symptoms with like a rotator cuff tear as well as like cervical radic and stuff like that. So she also on her last visit she also had like bilateral edema in her lower extremities. For a patient like that, she was nearing the like she was getting to the point where I was ready to discharge her, whether she was like, I need to be here to continue doing stuff. But I'm like, you know, the stuff that you need to do. But because there was that change, that evolution in her symptoms, I'm like, oh, we definitely need to keep an eye on this. I'm here now, not just to treat your symptoms, but I'm also here to monitor and make sure that you are referred to the appropriate sources, that you're getting the care that you need. And that to me is like something that you can definitely keep on as things change.
Yeah, so like a bit of nuance there too, right? Like, okay, if there's someone who has a presentation that is, evolving or changing, visits, you still think they get benefit from PT, at least when it comes to like a monitoring reassessment standpoint. Yeah, that maybe they're on longer, right? So yeah, that's a case where, keep someone on longer. And maybe like, not that they're not ever going to be discharged, but when we're talking about a more common patient presentation, acute or like your regular type of shoulder, back, neck pain, whatever it is, yeah, that maybe a more complex patient, like there's an idea for discharge, but the length of the plan of care is maybe longer and it's maybe a little bit more variable, but it's certainly justifiable.
So when you're getting ready to discharge someone, like how do you get them to transition from coming into PT once or twice a week and staying with that, because they're kind of required to do it, but when they get home and they don't come in anymore, do you expect them to continue doing those exercises all the time? Like what exactly how do you go about that?
Yeah, there's a certain way to do it. It's kind of a loosely it's adapted from like a MDT approach, right? So initially, if I find a certain movement that is consistently reducing their symptoms, then initially they're doing it pretty frequently, right? The idea is over time they can taper off, and there's certain criteria you look for in terms of symptomatic response when you would know they're ready to taper off from that exercise. So let's say we're down the road, their symptoms are gone, their symptoms have been gone, mostly, right? Maybe, if it's a little bit of pain intermittently, right? Sure, let's say that's fine. But let's just say for the purposes of this conversation, you have a patient whose symptoms have been abolished and gone, they haven't come back for a few days to a week, something like that. Then we'll trial maybe a week or two of them just kind of doing doing whatever they want, trying activities that were previously symptomatic. And then the information I give them in terms of what to look out for is, okay, you're looking for any kind of symptoms coming back, returning. If they had extremity symptoms, you're looking for return extremity symptoms. And then they're also going to be looking for how long the symptoms are lasting, and if there's any consistent pattern in terms of when the symptoms are coming on, right? So that's, I guess, a step before they're being ready to discharge. But that kind of information is also what I want them to look for afterwards, right? So let's say they're doing all their kind of previously provocative activities, they're fine, they're sticking with their exercise. Then at that point, I'm telling them, listen, you've kept up this, you've done all the work, you probably don't need to do this exercise as frequently. The only time they would have to get back into doing the kind of exercise or exercises that were helping them is if they notice a reduction in range of motion of that previous exercise. So let's say lumbar flexion was the movement that was helping them. If they notice, like, for a couple days in a row they have stiffness, they have some pain, and they can't reach as far down, all right, they're getting back doing that same kind of movement, right? And then they're also looking for if they would develop any kind of the symptoms that they were having previously. Let's say they're having anterior thigh and shin symptoms. Yeah, if those develop, then clearly they're going to try the exercise, they're going to try the exercise that was previously helping them to address that, right? Typically we see that, maybe not typically, but unless something traumatic happened, or historically they peripheralize instantly. Typically, we're looking for more peripheralization pattern where they would develop central spine stiffness or maybe pain, and then it starts to travel down the leg, right? So all those kind of factors when it comes to symptomatic response, stiffness, symptom peripheralization, symptom response after activity are what I am preparing them to look for before they're discharged. And then the information I give them in terms of keeping up with the exercise is only if you feel like you develop any of those symptoms, the stiffness, the extremity symptoms, stuff like that. So yeah, my expectation isn't that they're always doing this exercise, and I don't even really want them to have it in the back of their head that it's something they always have to keep up with. I'm giving them they're given the control. They know what to look out for. They understand that, hey, I'm feeling good now. It most likely will stay like that, but sometimes these things come back, and they know what to do if it does come back. So nothing like too, it's not realistic that they're going to stick with this kind of exercise for the rest of their life, right? So my perspective is, why don't we just teach them how to manage and monitor the symptoms on their own, which they're being taught that from day one. Now they get these symptoms in the future, and they try that same exercise and it goes away. They just know exactly what to do, right? They don't have to come in for visits. They don't have to contact me. And yeah, the controls, with the patient, which I think it's a really powerful way it's a very powerful method that, a patient being able to treat themselves, right? You don't really get that in other kind of healthcare disciplines. You have to go to the office, get this kind of medicine. Someone be able to monitor their symptoms, assess themselves, and then apply an intervention on their own I just think it's a really powerful and powerful thing.
Sure. And for the people who are listening, if you're not familiar, I just want to clarify. When Mark was talking about peripheralization, that is in regards to like spine symptoms and radicular symptoms. So there is a phenomenon that is called peripheralization and centralization. And that is pretty much where if you do an intervention and you notice that their symptoms are traveling further away from the spine and going out into their extremities, that is considered peripheralization. And generally that is a worsening of their symptoms. And centralization is the exact opposite. That's usually when you would notice that the symptoms are traveling back. And I usually like to refer it to patients as retreating towards the spine. And that is exactly what we want. And usually a a pretty powerful indicator that they are going to be a good responder to the selected intervention that we're using. Just want to clarify that because we haven't exactly delved into our spine as a major topic yet, which we will in the future, but just so that way everyone's on the same page there. Now, I do want to touch back on the topic that you talked about before, which was teaching patients the test retest method. And it's something that we've talked about previously all the time about how we use it. And I found this to be so powerful to patients, which is where they see our assessment. They see how we're going about in regards to troubleshooting their issues and how we systematically do it. The other part that I really enjoy is it depends on the patient, but the people who are receptive towards it, I will actually explain to them exactly what I'm doing. I treat them as if they're almost like a colleague, and I tell them like, hey, so this is how I go about like problem solving. This is how we like methodically break down what your issue is and find out where it's coming from. So when they see that, you are essentially being an example for them to follow. So that way, when they go home and we send them back to collect data, they're able to do so because they saw how we did it in the clinic. And then after that, when they're discharged, they're able to emulate that behavior. And so if they have to come back in, I usually have really, really good success with patients like this because they'll go back and then they're like, well, I started noticing that I had symptoms with XYZ. And so I did the exercises that you told me and I noticed these changes and I kept going with it, just like you said, but we've kind of hit a plateau. Things haven't really changed much. And that's where we are. They just did a huge chunk of my exam for me.
Yeah, you already have you have a good starting point already, right? Yeah, like you said, it's like, well, thanks for saving me 15, 20 minutes. Now we're going to start right here.
Yeah, like it just makes your job so much easier because now they're not just a patient, they are an ally to you in regards to like collaborating and helping you figure out, okay, these are the things that they noticed. We don't really need to check that anymore. Or if we do, we can be a little bit faster with it because we're able to know, okay, this didn't work. So like, why would I have to recheck it? And so then you can just progress your treatments a lot faster and be a lot more efficient with your treatments. So the one thing I do want to ask is, you said that for patients who have like those ridiculous symptoms, we usually anticipate them to be faster responding or that they're able to self-manage, and it's a lot easier to determine through test retest like whether or not that intervention helped previously is going to help moving forwards with their new symptoms or the recurrence of them. But that's most specifically to spine. How do you approach that when it comes to like other joint or muscular or soft tissue pathologies? How do you go about that? Because there isn't a reductive motion for that.
Yeah, so maybe these like, maybe slower responding type presentations. Yeah. So this one's kind of tough. Like maybe let's just say let's say like a small muscle tear or something like that. Something we know it's going to take time in terms for the tissues to adapt, in term for that to improve, for pain to reduce, stuff like that. Typically, what I'm looking for, I'm just we're reassessing impairments. We're getting input from the patient regarding like their functional improvement, stuff like that. But when it comes to exercise, things like that, the way I approach it is that, like, let's say I still taper off the frequency. So maybe, they're doing daily, couple exercises daily for whatever they're coming for. They get to the point where they're improved, they're doing everything. Maybe they still have a little bit of like lingering pain, but it's easily manageable. It's steadily reducing. At that point, I'll usually cut the frequency of their exercise in half. So maybe we go from every day to, 3-4 days a week. They'll do that for maybe 2 or 3 weeks, and then I'll cut it in half again. So now maybe they're doing it twice a week. And then as long as they're still good and maybe, they're self-assessing, this is past discharge at this point. As long as they still feel okay, those tissues have made those adaptations. They're functionally not limited. Their pain's gone. I don't think they have to keep doing the exercise at that point. It's a very loose recommendation, and the guidelines for them, at least the way I implement it, are a little bit less clear in terms of if they have to get back to doing the exercise. Those individuals I typically recommend, they contact me to see what's going on. Like I had someone recently, like a plantar surface foot pain, right? I didn't see them very frequently, but the course of care was probably about like 8 weeks. It took a while. They had a flare up. Gave them a little, but when it flared up, they had. It was when I had recommended to them to reduce the frequency of their exercises, and they were good for a couple weeks, and then they basically stopped doing them. Not stopped doing them. Maybe they're at the point where they're doing like once or twice a week or as needed, and they had just restarted a running program at that time. Well, in that kind of case, like I said, it's a little bit more loose. The monitoring is a little bit more specific. Yeah, maybe they're adding this extra stress, this different variable. Maybe because of adding in that extra variable being running, they have to keep up with exercise a little bit more, which ended up being the case, and they did fine. But when it comes to those slow responders, those maybe like soft tissue dysfunction type of things, those presentations, yeah, it's a little bit more loose and individualized when it comes to how they are maintaining the progress they've done. I mean, I still give them recommendations when it comes to monitoring for like pain, reduced function, stuff like that. But when it comes to them keeping up with it, I don't have as specific of a recommendation. And I think this is just because I don't know of any kind of system that has outlined specific recommendations in that regard. It's kind of just like, hey, here are your exercises, you do them. I try to give them things to look out for, but at least in that presentation, for me, it's a little bit less strict. How about you? What are you doing if you want to use the same kind of, if you want to keep it consistent? Let's use like a small cuff tear or something like that. Something that took a while. It's certainly responding, got better. Like, what do you do with their exercises past the after discharge or preparing them for discharge?
Yeah, sure. So I was actually going to ask you a question in regards to that,
Yeah.
but and my question initially was like, do you change their home exercise program on discharge? What exactly do you give them? Do you give them harder things? Do you give them more stuff? Do you give them a bunch of exercises for them to dig through in their toolbox? And I've noticed, at least in my own practice, it varies from patient to patient for the most part. But my prescription tends to stay relatively the same and similar. So I will usually give them very easy things that specifically target the impairments that we need to target. These are the things that I anticipate will give them issues if they return. So it also kind of leads to the next question, which I'm sure that we're going to tie back into, which is, are we looking to get patients back to their previous level of function, like we always write in our documentation, or can we actually look to supersede that and go above and beyond that, so that way we quote unquote prevent a recurrence of it? So to answer your initial question, most of the times when I give a patient something, let's say for the example that you gave was a rotator cuff, right? I will usually give them something that improves on their posterior cuff activation, as well as mobility. If things start to go, I find that mobility is one of the first things that I can do to help calm down the shoulder. If you're restoring its function, joints and tissues are usually going to be happier from there on out.
So you give
Improving
that to them,
posterior.
like you'll tell them, hey, if you notice that things stiffen up or get a little bit irritated, this is the first thing they should try, which would be addressing mobility.
Yeah, so
Gotcha.
I
Okay.
usually
Okay.
actually walk them through the initial part of like how I go about addressing their issues. And I usually address cranky shoulders by offloading them. I will not load them initially. I will work on isometrics, passive ranges, and stuff like that, doing the things that they can tolerate and gradually looking to restore their function without further irritation. And when I walk them through that and they're able to see why we do that, because if the tissue is less irritable, we're probably going to get better results out of it. But when they can see that process firsthand, it makes a whole lot more sense for them to do so when they're at home. So when they are out of my care and they understand that, that's when I give them the specific interventions. I usually just give people like 3 exercises tops for something, and just to make sure that they're able to follow and stick with it. There are other patients for a rotator cuff. Like I can think of one off the top of my head right now where she still has pain. She's very, very functional, much better than before, but she still has some residual stuff. And I gave her a bunch of things for her to continue working on because she's compliant. She will do those exercises, and that way she doesn't get bored. She will have multiple things to continue progressing on. And I just know that she's going to cycle through them very, very well. And to me, that's a very specific patient that I'll give that to. It is not very common that I'll do that for someone. People tend to like things that are easy, simple, low barriers to entry. And that's typically how I'll manage their home exercise program to make sure that they're able to troubleshoot things or manage their symptoms as best as they can. I don't expect them to have the same clinical judgment that you or I would have in regards to addressing their symptoms. We give them the first line of defense to assess and treat their issues. And if it doesn't get better, come on in. Right. I don't expect them to be able to fix their problem. That's our job. You know?
So it's not, you aren't in this case, you're not telling people, hey, if they come back, just give me a call, come back. They know what to do as the first line of defense. And if it doesn't start to resolve like it had when they were seeing you, okay, that's when they come back.
Yeah, pretty much. Because like I said, if they're able to manage their symptoms, and most patients will do this, even if they haven't seen you before, they're like, well, I started having symptoms like a year ago, and then it kind of just went away once I started doing this, and then it felt better. And then it came back again, and that's why I'm here. So it's like you have that plateau, and then it comes back, and then that's when they're here. It would be virtually the same exact thing. They try this, and this time with more guidance and more experience and less fear of navigating through their symptoms, and they're better able to like present their symptoms to you if they do come back for another eval. So I find that to be like really, really effective in just like empowering them that, hey, you can do some of this stuff too. Like, obviously, I don't expect you to do all of it, but it gives them some power to take control over their health and at least not be scared of trying to troubleshoot it.
Yeah, exactly. That's a good point when it comes to the troubleshooting and they have the ability to kind of poke around, figure out, what's working, what's not. At least it's all these kind of concepts that they're picking up from you when when they have sessions, stuff like that. They know what to look out for. They understand how to address the issue if it does come back. You said about I I just want to butt in quick because you mentioned
go ahead.
You said about in terms of discharging people, maybe you want to get them past where they were. Are there ever any cases where you're discharging people when they're not back to where they were? Maybe a slower responder, they're doing the right thing, it's just going to continue to improve, or anything come to mind in that regard? Or I should say too,
Sure.
like, do your discharge criteria, are there ever any cases where, your expectation is that they won't require skilled care, past a certain, percentage of improvement, but your general expectation is that they'll get to 100%.
Yeah, so you actually read my mind. That's what I was trying to tie back in, because I think it's such an important conversation to have, right? Like, obviously, I want to get people better. I want to get them stronger. That is just progression, right? And I think that that's super important because you improve on their function, you improve on all the things that are valuable as like potential deficits to make sure that they aren't regressing. And to me, I think that it is a great goal to have, but I also feel like it can often be short-sighted a lot of times, or maybe not short-sighted, but maybe a little naive. And that just comes with more practice. To me, when I have a patient, I am obviously trying to do that. If I can get you better, stronger, and being able to do all the things and more that you wanted to do, that's awesome. That is a home run. I will say that is not usually the case.
Yeah, I agree for sure.
A lot of times for patients, if I can get them, like they're coming in with an impairment, and some patients are, they're at varying levels of health with different conditions and stuff like that. It becomes a challenge to even return them to their prior level of function at times. And I think that is something that we need to be aware of and acknowledge that, because it is, I don't want to say it's a limitation for us, but it's essentially setting us up for unrealistic expectations and goals. Yeah. And so when I have a patient, sometimes I will be getting ready to discharge them because they're progressing slowly but surely. And I'm like, you're going to get better. You will get there. You may not be 100%, but you will continue to improve with time. And that's okay. I have no qualms about that. They usually end up doing just fine. They're on the same page for the most part. The second type of patient is where I can't get them any better. I'm seeing a hard plateau. And sometimes it's like their body structure, I just can't really change. Or like my interventions are limited due to some of their other impairments. And I think that is like, you have to be able to have that conversation with the patient to make sure that we're on the same page. Like I always tell my patients this on eval, like, hey, I don't know if I can fully get rid of your pain, because that if I guarantee you that is a lie, right? I do a pretty good job of managing your symptoms and being able to get you to feel better. And that to me is already like something that most patients fully understand. They aren't like, oh, you guys are going to fix everything. They realize that they've had this issue for a long time, and that sometimes complete resolution is just out of the picture. If we get it, awesome. But I don't want to put that idea in their head and give them false expectations. That usually just sets them up for disaster going down the road, where they feel like, oh, I didn't get this, I didn't get that. Well, I'm not getting any better because I still have these issues. But it's like, look at what you can do now. Look at how far you've come. Let's focus on that instead of like, oh, well, I still have pain when I move in this specific way. Yeah. Chances are like you can avoid that.
Yeah. Do you find, like, let's say you have a couple sessions and someone, session one, or the first follow up, they're like 30% better, second follow up 50, third follow up 75. Like, even though maybe at the initial evaluation, you give them a little bit of an idea, like, hey, you had a good response today, it should continue, but I can't guarantee that, we're going to have to see what happens going forward. If you go a couple sessions and, you see this trend continuing and that they're responding quickly, they're rapidly improving, do you give them any kind of additional reinsurance? Like, hey, this, we talked at the eval about, where I think this would end up, or where it could, let's say they're just consistently heading in the right direction. Will you ever make a more targeted statement such as, hey, like, this should go away completely? Or do you just continually reassess and, just give them an idea of where they're at in that moment, within the session that you're seeing them?
Definitely more the latter. Yeah, I do not really guarantee any like complete resolution. Mm-hmm. If it happens, it's cool. You feel like you're the man and that you crushed it. They're wowed by it, and like that's a great feeling, right?
There's definitely a little bit of like showmanship in that regard. But like I think I know what you're gonna say, but yeah, go ahead.
Yeah, for the most part, I just reassess it and I just tell them where they're at. Like,
Yeah,
hey,
exactly. Right.
look at where you're at now. Your symptoms only come on at XYZ instead of like all the other times. It's decreases in frequency, severity, etc. You know, like these are all the deficits that you've improved on. You're doing great. This is awesome. And I at the very most, I'll tell them these are all positive like predictors for how you're doing. Like, I think that if we get to see those positive indicators and we relay that to the patient, they're like, oh, this is great. Like there's a chance like that we can get it to go away, but like it also may not happen. I try not to put that in their head, but the fact that they know that they're responding well definitely gives them a lot more hope and motivation to continue improving because they're seeing those positive effects. It's essentially just a feedback loop where they're like, oh, I'm doing great. I'm going to keep doing what I've been doing to incur those further changes, you know?
Yeah. It's like, all right, you know, this is what my PT is telling me. This is the kind of response I'm supposed to look out for. This means it's getting better. This could mean it's getting worse. Yeah, and that's you know, they know what to look for. So how about, like, I think this will be a good topic to wrap up for. Is there anything, like, in terms of prevention? We talked about discharge criteria there. Let's just speak generally. Start. Do you find is preventing symptom recurrence something that's possible?
Yeah, I think that the whole concept of prevention is very interesting because, like, how do you know that if they're coming back in, if it's the same issue?
Yeah,
how do you know it's not a different thing? You know, like there could have been other things that you're like, oh, if we fix this, then we're going to prevent the recurrence of this going on down the road. We actually have no idea if that's going to be the case or not. I used to be a huge advocate for this concept of prehab and preventative things. And I still am to an extent. I think that improving on deficits is always going to be a good thing. Well, aside from the fact that it takes time, it's a lot of effort. You know, like I'm sure that you've run into a couple of patients where, like, especially gym goers, where they're like, oh, I need to warm up for like 45 minutes. I need to do all these different like mobility and
they got every band, every foam roller. Yeah, it's like, all right, man. Let's exactly. They're on the ground rolling around, and then you know you're done lifting. All right, see ya. Huh.
So it's just like that is when it just goes too far for me. I think that's cool if that's what you want to do, but I am not going to put that it's almost like a time burden at that point on my patients where it's like, no, you need to do these things. Otherwise they will come back. That's just like, I feel like that is taking away so much of the work that you've already put in. Like you've built them up so much that you should be able to continually progress them, or they should be able to progress themselves without having to revert back to doing all of that stuff. You've laid that foundation. And to me, it's like, intelligent programming to be able to continue improving on those deficits while still living your normal life, while still training the way that you want to train. So prevention for me is like, yeah, I can teach you a lot of things. If it's preventable, I absolutely will try to do so, or I'll at least teach you how to manage it. But the whole concept of preventing an issue or potentially preventing an issue, I don't know how much I can buy into it as much, aside from maybe like tendinopathies or potential, sometimes even ruptures, which is just taking care of your tendon health, taking care of your joints and stuff like that. Just being mindful of these things and using the appropriate fundamental principles to ensure that things are moving well, things are happy, that you're addressing these deficits, you know how to look for them and stuff like that. I think that's definitely going to help. But if we're talking about like setting patients up in the future and you have that conversation about preventing a recurrence of it, I think that is a much harder sell to make and to justify, because we just don't have that evidence to say that, oh, this is this is what's going to fix you and keep you fixed.
Yeah,
I
yeah.
just don't think that that's the case with time and changes happening. And like, I just don't know how that you can reliably prevent things.
Yeah, like you said, there's not really, we don't have data to suggest that, hey, if you do a certain thing, or if you um eat a certain diet or whatever it is, that you are going to prevent whatever kind of symptoms you had before from coming back, right? So it's the conversation is always interesting, because typically a patient wants to know, okay, what can I do so this doesn't come back? I mean, at least the way I phrase is that, these are, it's possible this can come return in the future, but these are the things that you can do and continue doing to reduce the risk of it coming back. I never use the word prevent, right? If you tell someone, hey, if you do this, this will prevent it from coming back. First off, I mean, based on any kind of available data, you don't know that. Second off, if it does come back, I don't know how much the person's going to trust you, versus that, hey, these are the kind of things you did while you were coming for PT. This is what helped. This is the way you're going to continue to self-monitor and implement these concepts, or if we're talking exercise in the future, to give you the best chance of reducing these symptoms from returning. Prevention would mean it doesn't come back. I think the management of symptoms, if they do return, is at least for me, like the main kind of message I'm trying to get people to understand when they're discharged.
Yeah, for sure. And I think like one of the bigger things that I'll have this conversation with is if they are very active, if there's someone who is like very already knowledgeable about this stuff. Like they go to the gym a whole bunch, they read up and they research on it, and or they're like a potential competitor. I think that they are much more in tune with their bodies, and they're also a lot more willing to invest the time, energy, resources, etc., to actually assess themselves and find out what these deficits are and to continue
Yeah.
improving on them. Like those patients, I will actually take more time to explain that thought process and teach them, hey, so if you're noticing like these things, like maybe you're starting to lose some range of motion because of either a tightness, like muscular or joint, then it might be something for you to address before it gets out of hand. Like you want to make sure that they're able to stay on top of it, because that's what's going to keep them healthy,
Yeah.
right? Like to me, you're just teaching them the same skills that we have to be able to self-assess and then how to problem solve that moving forward. But for the average person, I don't really think that that is plausible. I do not expect them to be able to do the things that we do. They just don't have the training for it.
Yeah.
Nor do they want to invest the amount of time or resources learning about it.
Yeah.
And then essentially just like going through it for the first time, trying to figure it all out, making sense of it. And it just seems unrealistic.
Like you said,
to me.
making sense of it. I was just gonna say, like, someone who's maybe not familiar with exercise or like training for a specific goal, like physically, like they might not even have the background knowledge or like understanding of, like not only how to do these things, but like why it makes sense that it's possible that symptoms do return, right? When we're talking about someone who's like a competitive athlete, may whatever sport, I think they have an understanding, like, hey, yeah, I train hard, I take care of my body the best I can, I manage my training volume and intensity as best I can. But it's normal that if you're training hard and doing stuff, like, yeah, sometimes things might hurt a little bit. It's not normal that it would bother you to the point where it limits your performance, right? But yeah, sometimes things ache, things like that. And I think those individuals have a better understanding of, like you were saying, what to look for and how to manage things. Whereas maybe someone who doesn't have that information or background, all they think is, oh, well, I didn't have pain before and, it went away, but like, why would it come back? Right. It's, yeah, get a little touchy.
Sure. And I think the really big selling point on this in my head is that how do we expect our patients to be able to understand this when for a large amount of cases, PTs don't even understand the patient's symptoms.
Yeah.
Like, how are we expected to have patients be able to do essentially our jobs and figure things out when a lot of PTs don't even understand, like, oh, this is the deficit that we need to be fixing or addressing, and this is the targeted intervention that we need to be doing.
Yeah.
Like, it is wild to me
and it's
that.
Go
Go ahead.
Yeah, well, like building on that, like I think the big reason why some PTs aren't able to like make this connection is because the program that they have the person doing is so general, and they're maybe coming in doing 10, 12. I mean, I've seen people do like 18 different exercises in a single session, and their home program is never changed from the first visit while they're doing all these exercises. So they get the discharge and they're just like, like, oh, keep doing your exercises, when you're doing so many different things, you don't know what's helping. And then, there's just like no guidance. There's no, there's not really like an expectation. The patient, I mean, like you said, the PTs has the person doing all this kind of different things. And, there's no way they have a clear understanding of what's happening when they're doing all these different kind of movements. And there's no questioning in terms of like symptomatic response, stuff like that. How do you expect a patient to be able to reassess and understand like what's going on and what they need to do going forward if, like you said, the PT doesn't have control of that either?
Yeah, and I definitely agree with that. And that's why, like, to me, I think it's so important for us to elevate our standard of care, is because that way we get a better grasp on these things. We develop a better system. There are changes that we're implementing either for volume, for load, for our exercises. They are targeted interventions. That is our job. That is what separates us from like being a personal trainer, essentially. Is making sure that our interventions are specific to our patients' needs. And that is what's going to help fix them. So when we elevate that standard of care and patients see that, they understand it, it makes it a whole lot easier for them to start to implement some of those things, because we're the example. We're the ones who are guiding them on their journey to improvement or to reducing their symptoms. Like, I just think that is why I personally feel super passionate about this stuff, because I want to make sure that it's not only our field that gets better, that our patients' care gets better, but also just improving health literacy across the board is so important.
Yeah, especially like just because we talked about two different patient populations when it comes to prevention, discharge, and discharge criteria, things like that. Like the people who don't exercise regularly and aren't really physically active, they may be okay coming in and doing the same kind of programmed bunch of exercise for 40, 50 minutes, an hour, whatever it is. But when you get the people who are training for something specifically, or who, they exercise on their own, multiple times a week, they're following a specific program, like I don't find that they're particularly receptive to coming in and just doing a real general whatever kind of routine. Like they're looking for things they can do on their own. They're looking for self management. They're looking for reassessment. And what comes when you do all of that, which is also what they're looking for, is understanding of what's going on, how they can manage it, and why what you're recommending them to do is going to help them. So like when we talk about elevating the standard of care, like I think not that a certain individual is more important than the other, but like we have to know what when you're talking about standard care health literacy, like an individual who isn't physically active, I don't find that, setting their expectation to be that they're going to come into a session and then, they're doing, just a random list of exercises for 40 minutes. And by the time they're done PT, they're just going back to doing nothing. Like it doesn't, I don't know if it sets them up to be able to understand better.
Yeah, I think like the expectations that we have for our patients definitely differ. If I'm treating someone who is like a competitor, I know that for the most part, they are going to be very self sufficient. They want the targeted interventions because if they are already really strong, if they're already like in really good aerobic condition, like what can I really offer them in that context, right? Like that's not what they're here for. They're not
Yeah.
here for generalized
Oh,
strengthening.
yeah, yeah.
They are here to fix their issue. And if you're working with Gen Pop, I think that if you expect them to walk out and try to become the pinnacle of health afterwards, I think that is like being completely delusional and
Yeah.
essentially setting up your patients for failure,
Yeah.
because you need to understand like what they want to get back to doing. People just usually want to go back to living their lives, and whatever their life looks like, that is radically different. Maybe someone needs to run a marathon. Maybe someone needs to go back to gardening.
Yeah.
It's these things that really dictate how you communicate with your patients and how you adapt your treatment of them. And it's not like we're treating them differently, but we're just addressing their respective needs.
Yeah.
And I think that is so important. But the one last thing that I do want to talk about is in regards to prevention. And I think that this should be a topic on its own, and I'm sure that we'll come back to it in the future, which is if you're working with athletes, the best way to me in regards to mitigating injury or prevention or anything along the lines of that is load management. And I think that is something that really, really goes overlooked, and people just seem to not quite understand it. And like load management, to summarize and put it like pretty succinctly, is managing lifestyle factors, managing all the stressors for your patient. So whether it's their actual training volume and program that needs to be addressed, their intensity that needs to be addressed, maybe it's their sleep, their nutrition, their work-life balance, etc. All these things are contributing to like the stressors in their life. If we don't do, or if we don't teach them how to manage that, you're essentially just going to set yourself up for injury or for a decrease in performance, right? Like if you have poor sleep, that is going to really negatively affect your performance and your ability to do a whole lot of things. And it really sets you up to re-injure yourself. And that to me is like a very important conversation you need to have with your high performing athletes or patients to ensure that they continue performing at the level that they want and addressing these things that they may have neglected or maybe they didn't prioritize previously. What are your thoughts on that?
Yeah. Like load management is when it comes to that population, especially people like, I don't know. I mean, I have some people come in, especially higher level athletes, competitors, whatever it is. They exercise. They know what to do. They have minimal deficits when it comes to whatever it is, strength, range, motion, stuff like that. But maybe they're missing that single component. Hey, let's take a look at your program. Let's take a look at your like training volume. Did you have any spikes? Did you have any rapid decreases? Did you change any kind of movement that you're doing? The way that presentation is assessed and their expectations going forward when it comes to PT and when it comes to prevention is vastly different than you said, Gen Pop, someone who wants to just be able to like even like sitting in a chair without pain, right? We're looking at different things where if you have that first person come in and they're doing all the exercises and they have knee pain, something like that, and here you're gonna do some quad sets and then the quad stretch. They know that kind of stuff. That's not the answer they're looking for. You've lost them already. But unfortunately, that is almost like the standard of care, at least from what I've seen. But yeah, like I said, probably. I mean, we'll definitely touch on this in the future. But the load management component and really getting an understanding of the individual, is essentially what that kind of population is looking for. Obviously there's cases where they have specific physical impairments, but yeah, you have to know the most important person is the person in front of you. You got to understand what they're looking for. You got to understand where they're at, and without without talking to the person and reassessing and knowing what they're looking for, you're just not going to get there. All right. So to summarize today, we talked about what we're looking for discharge. Biggest thing it seems like that Ken and I have come to is that the individual needs to know what to look for in terms of reassessing themselves and understanding when it's necessary to implement the exercises if it's been recommended to them to stop, and understanding to what degree they need to continue the exercise if that had been recommended to them to continue with them. Expectations are another huge thing. They need to understand that, hey, it's possible that these kind of symptoms that are gone now come back, but we've talked extensively about what you're supposed to look out for and what you're supposed to do if they do come back. Another thing we talked about, prevention may, or at least in most cases, it's probably not 100% realistic, right? Just how I had spoke about reassessment when necessary and implementing their management strategies when it comes to reducing symptoms is essentially the key going forward. If you're telling someone that you can guarantee that their symptoms aren't coming back, essentially lying to them, you're setting up false expectations, and it's really not realistic. Yeah, and besides physical factors, load management is like a huge component. We can't talk about lifestyle factors when it comes to sleep, stress, things like that. Really get an idea of where your patient's at, what they're doing. Their level of activity is going to give you the best idea of what information they're going to go home with when it comes to discharge, and what they're going to have to keep working on when it comes to reducing the risk of their problem coming back. All right. Thanks for listening, everyone. We hope you enjoyed this episode of the PT Good Podcast. Remember to leave us a like and to subscribe to us on whatever platform you're listening us to, and we will see you on the next episode.
Miss you, love you, bye.